it's not burnout, it's moral injury.
Moral injury is a phrase that was first applied to service members who had come back from war and had seen some really, or been asked to do some really egregious things. And so it's bearing witness to an act that transgresses deeply held moral beliefs. And in healthcare, those deeply held moral beliefs are the oaths that we took when we left training or left medical school to put our patients as a priority. Over the course of several years, my co-author, Simon Talbot, and I had been talking to friends of ours who were saying, we are struggling. On paper, they looked like they were at the tops of their game. They were in big academic medical centers. They were experts in their field. And yet they said they were still struggling. And we asked them, I would say to them, well, okay, you're burned out. Everybody, that's the big thing in healthcare right now. And they would say, no, that's not quite right. I love medicine. I love my patients. What is just crushing me is everything in between and everything around that interaction. The EHR, the prior authorizations for healthcare, for health insurance companies, the mandates that the business framework of healthcare puts on what I can and can't do. And if I could just wipe all of that away, or at least reduce it to a manageable level, I would be great. I knew going into this that this was going to be a hard job. I was going to have to work crazy hours. But what ends up happening is we can't practice medicine the way we thought that we would be able to do. And what that ends up doing is we feel like our hands are tied. We know what's the right thing to do, and we can't get it for our patients. And that is what is the crux of a moral injury. Each one of those things is a moral insult. And as they amass over time, days, weeks, months, years, it becomes a moral injury where we begin to question how we can maintain ourselves as a moral being and continue to work in an environment that doesn't allow us to do what we believe is right for our patients.
So I'm getting the mental picture of kind of like death by 1,000 paper cuts. I like the word injury because there's a real range to that, isn't there? And I imagine that it can start in subtle ways, and the moral injury can happen, as you said, as it amasses over time. We may not realize that we are sustaining moral injury when it begins.
Correct.
Or it could be a big event that is a real obvious, like akin to losing part of a limb.
Right. So I think there are two ways that you can come at this. It can either be a massive episode where, for example, with military service members, typically their episodes of moral injury may come as a single act. Mm-hmm. But with healthcare providers, any one of the insults could probably, if they were isolated and they happened once in a very great while, you could heal from that. You could process it. You could say, that it was not ideal, but it was such a rare occurrence that, sometimes things happen that we can't prevent. But when it happens repeatedly every day and multiple times a week, a month, a year, it becomes that death by 1,000 cuts. And it's painful for clinicians.
So I know that in the beginning of I read the research paper on the link that I found, and a couple other definitions that I read. It starts, okay, so it started with military, but then it moved to physicians, but then the conversation has expanded, as you said, to include all the clinicians, caretakers, understaffed assisted living facilities where there are too many patients for one aide to do critical things like personal hygiene and toilet assistance, things that really can't wait, and I know that when I've been, visiting friends who are in those facilities, it's very stressful for me just sitting there watching them try to do their job. And I can't imagine what that would be like day after day. So it's not just the top, like the physician on the top of the
Absolutely.
It goes all the way down to the base.
Absolutely. So what we've heard over the past 18 months since we published our first article, which was really a thought experiment, we didn't realize how profoundly it would resonate, which has been frankly heartbreaking. But since the publication of that first article, we have been very clear from the feedback that we got that this is not just physicians. This is across the spectrum of licensees in healthcare, EMTs, respiratory therapists, physical therapists, nurses, nurse practitioners, physician's assistants. Everybody says this is their language. And even some administrators have said, this is my language. So it is very much across the board in healthcare.
Because I remember that part in your article where one of the remedies was for the medical teams to invite administrators to follow them around for a day.
Correct.
Can you talk a little more about that? And what would you hope that the administrator would not only see, but really understand?
I think there are two things. I don't think any of this is nefarious. Let me just start by saying that. I don't think that administrators have set out to create an environment that harms patients and clinicians. I just don't think that that's the case. What I do think is that starting around sometime in the 80s or early 90s, as reimbursement became much more complex with the advent of managed care, it became harder and harder for clinicians to be able to both manage the clinical side and manage the reimbursement or billing side. And so they abdicated that responsibility and those tasks, that side, they abdicated the business side of medicine to folks who trained and were experts in business. Unfortunately, those folks in business don't have any clinical background. And so it's hard for them to understand how clinical medicine operates. It is a different beast. And I think the problem is that we have not done a great job of talking across that boundary. And as time has gone on over the decades, we have diverged further and further. So business has gone in one direction, clinicians have gone in another, and we've talked to each other less and less. As clinicians have gotten more busy, they have had less time to engage in the decision-making of healthcare. And so it has been relegated more to non-clinicians who are doing their best, but may not understand the clinical implications of the decisions that they're making. So on the one hand, doctors don't understand the pressures that the administrators are under, and the administrators don't understand the pressures that the doctors are under. And so I would like to think that if we can talk to each other and understand each other better, both our motivations and our incentives, that we can come to some middle ground.
So I find that really interesting. So your specialty is psychiatry, is that right?
Correct.
Okay. So you must have a lot of people coming to you. I mean, as the therapist, I'm sure that that you're a go-to person because they know that you understand the rigors of going through medical school and that phase of visualizing what a career will be like in medicine when you finally get out there and get your license and all that. Can you give an example, maybe one of the more drastic examples of moral injury that you know about?
So there have been a lot of stories. I don't even know how to come up with one.
Or you
Um,
just like put a few cases together into whatever. Yeah.
so social media is great for coming up with these stories.
Mhm.
So for example, there was one physician on Twitter, I think it was, who said um, it, he was celebrating because after 3 months and three people working on it, he finally got approval for a patient to get their medication that
Wow.
they've needed. Um, you know, you multiply that by 30 patients a day, 5 days a week. Nobody, that was hours and hours and hours of time. And that happens more often than you might imagine. And the physician knows that in in the interim, when they're going through that process for 3 months, the patient is not getting the optimal care.
Right.
And that happens with MRIs, with I had another there was another person who said, "Oh gosh, look, my surgery was approved. It was pre-authorized. My anesthesia was not,
What?
nor were my narcotic pain medications." So,
And it's being not approved by people working for $20 an hour who are at a computer screen, who just have this power to just say no. I mean, who
so
are
it's
these people who are not giving permission?
so I think those are people who are doing their level best within the constraints that they have. So they have an algorithm that they go through,
No
and
anesthesia.
it points them left or right. And I think um, it's it's difficult for everyone. I can't imagine that the people who are approving or disproving um, those medications or those surgeries are are happy with what they're doing, because I think on some level they recognize it as well. But there hasn't been a willingness for everybody to stand up and say enough.
So are you suggesting that the folks in charge of approving are also having moral injury?
I think
Where,
some of them are,
I mean,
and
how
we've
does it
heard that
work?
some of them are.
I could imagine. I mean, and it's hard.